All right, good morning, and here is today's class on Chapter 33, Orthopedic Injuries. Like I said, we're going to try to cover as much as possible in this session. I'm hoping to get through all these slides in the 3 hours, so I'm going to try to speed up and cover as much as possible. Orthopedic trauma. So we're going to be talking about open and closed fractures, dislocations, amputations, upper and lower extremities, talking about those pathophys assessments and management of everything, non-traumatic issues, and musculoskeletal injuries. Okay, so these are often easily identified because of obvious associated pain, rarely fatal, but often result in some form of disability for the individual. Obviously, with this, we want to determine any life-threatening injuries before we manage these. These type of injuries obviously can be distracting to us, not necessarily to the patient, although they can distract the patient from other injuries that they might be exhibiting. But we got to be cautious, obviously, with musculoskeletal injuries that they don't distract us from the bigger picture and for managing any potential life threats. Never forget to assess, obviously, airway, breathing, circulation, other disabilities, and any exposure issues for the patient. Musculoskeletal system gives the body its shape and allows its movement. It is the foundation, basically, for what composes the body. It's the solid foundation. It's just like in a structure, we got to have a good foundation to have everything that's built upon. The muscles compose of specialized cells that contract when stimulated to exert a force on a part of the body. 3 types of muscles. There's the cardiac, the skeletal, and then the smooth muscles. Muscle contraction requires energy, which is derived from the metabolism of glucose and results in the production of lactic acid. Muscle innervation. Skeletal muscle is innervated by somatic motor neurons. The motor unit is a combination of muscle and the neuron that innervates. Recruitment, another term I believe, is to generate a more forceful contraction. More neurons need to signal more muscle cells to contract. Musculoskeletal blood supply is the skeletal muscle is supplied by arteries, veins, and the nerves. Blood supply in each upper extremity originates from the subclavian artery. So just as a good note. Most of us understand the skeleton is divided into 2 parts. It's comprised of 206 bones. You have the axial skeleton, which is the bones of the central part of the body, and you have the appendicular skeleton, which is the pectoral girdle, the pelvic girdle, and then your upper and lower extremities. Upper extremity is composed of the upper arm, elbow, and forearm. And it's important to remember that this includes that scapula as part of this. That's all part of that upper extremity. Radius and the ulna make up the forearm. We know that. You got the humeral bone. You got the glenohumeral joint, and then that scapula. The hand contains 3 sets of bones. You got the wrist bone is connected to the hand bone, and the hand bone is connected to the finger bone. It's a good song. So your wrist bones, understand the terminology for these groups of bones, right? So the wrist bones are your carpals. The hand bones are the metacarpals. and the fingers themselves are the phalanges. The pelvis supports the body weight and protects the structures within the pelvis. And we all know that there's major vessels that run through the pelvis, which damage to that pelvic bone can cause some serious, significant bleeding and other issues within the organs that are within that area. The pelvis has two iliac bones that are joined posteriorly by ligaments to the sacrum at the sacroiliac crest. I got to move something out of the way here. These are just in my way. So there's your iliac crest. Obviously, when we talk about some immobilization devices, we utilize the iliac crest as a point that we need to keep in consideration for traction. You have the sacrum, then inguinal ligament, the pubic bone, pubic symphysis, and then obviously there's your ischium. All right. Each lower extremity consists of the bones of the thigh, leg, and foot. The patella is the kneecap. Tibia, the shin bone, which is the bone that we're going to utilize for IO insertion. You got the foot that is connected to you got the ankle bones, which are the tarsals. The actual foot bones are the metatarsals, and the toe bones are the phalanges. A joint is formed wherever two bones come into contact, so that is important to understand. You know, I know for me, when I was getting started, I would always get ligaments and tendons kind of mixed up, it seems like. 2 o'clock in the morning, I still might get them mixed up. But understand what connects two joints. Ligament, right? They link the two joints together, and the tendon is what connects the muscle to the bone. Motions that affect that a joint may exhibit are flexion, extension, abduction, adduction, rotation, circumduction, pronation, and supination. So technical. The bone classifications themselves based on their shapes. Long bones are longer than they are wide. Short bones are nearly as wide as they are long. Flat bones are thin. Broad bones, irregular bones have complex shapes. And sesamoid bones or round bones are generally found in tendons. So it's good to remember these for some test question. Long bone architecture is divided into the diaphysis, epiphysis, I can't speak today. Epiphysis, there we go, and the metaphysis. You got those 3 points. Periosteum covers outer portion of the bone. It's important to understand. So there's the shaft, and you have the tips of the bone, and you have the section that connects the tip of the bone to the shaft of the bone. There you go. Where in these bones we have to be very cautious of is the growth plates when we go to insert the IO. So it's important to understand the bones, the sections of the bones, so that when we are applying an intervention, we don't cause further damage. Tendons are connected. We got that. They cross joints to create a pulling force between the two bones when a muscle contracts. The ligaments connect bone to bone. Cartilage is that fiber or the fibers of collagen embedded in gelatinous substance. Bone density decreases after the age of 35. Osteoporosis is associated with high risk of fracture. It's very common to see this in elderly females. And so a simple fall, ground level fall, can produce a fractured hip somewhat easily, fractured hip or even a fractured pelvis. That's why it's so easy for a lot of these elderly. They have that osteoporosis. Their bones are going to be a lot weaker. So bone density decreases, leads to a loss of height, and produces changes in facial structure, according to the book. In women, the decrease in bone density accelerates once menopause is reached. So that's going to decrease once menopause is reached in women. A significant decrease in bone density. Osteoporosis is associated with high risk of fractures. Aging of muscles, cartilage, and other connective tissues may lead to degradation of joints and disc herniations. So then you're going to see that with the issues of the back as well. Kind of increases with that. Injuries may result from both blunt and penetrating trauma. Pathological fractures are, you're going to have a medical condition causes the bone to become abnormally weak. You know, I have experienced a patient who, because of a seizure, end up having some fractures as a result of that. There's other medical complications, you know, obviously osteoporosis, as well as rheumatoid arthritis. The mechanism of injury can be a direct blow, indirect forces, twisting forces, or even the high energy injuries. Among children, intentional trauma or abuse is common cause of the fractures and musculoskeletal injuries. Sports injuries account for a significant number of the musculoskeletal injuries. Direct blow fractures are the bone at the Direct blow fractures the bone at the point of impact. Impalement injury is similar to low velocity penetrating injuries. Indirect injury occurs when force is applied to one region of the body but causes an injury to another region. Let's see where I'm at with the notes here. So with the impalement injury, stabilize the object obviously is to protect the soft tissue from further injury. That's the key with the impalement and stabilization of the object. Forces may be transmitted along the entire length of a bone and through several bones, like in a series. Identify the point of contact and the mechanism of injury to decrease the chances of overlooking any associated injuries. Twisting forces are a common cause of musculoskeletal injury. Some injuries are even commonly encountered together because of the way the causation forces are transmitted, if that makes sense. Right? Any other question? Any questions on pathophys? Any of that? I wouldn't expect any questions. So now we're going to get into fractures. Fractures. Open fracture, closed fracture. Pretty simple. Open fracture is when you have a break in this overlying skin, allows the fracture to be exposed to the outside environment. The closed fracture is when the skin over the fracture site remains intact. So your open fractures could be as a result of some type of external trauma causing that break, and then the skin ripping. It could be avulged, or the bone coming out of the skin. So you can have those compound fractures. Seems like some of the ones that most of the compound fractures that I've heard, it wasn't truly a compound fracture, but the skin was broken as a result of the mechanism of injury. It wasn't actually from the bone itself. Some of the common fractures we see are going to be with those, like those ankles. A lot of times those are just dislocated, but as you can see with the one here, that's not a typical dislocation. I've seen this dislocation once when I was doing my internship in Texas. It was a motorcycle versus two vehicles. He kind of got sandwiched, kind of a crazy accident, and his ankle rolled like it is in this picture. What happens is now that those bones are pushing up, causing issues. So you're getting breaks in that fibula. And this guy ended up having multiple breaks in his fib. His tib was fine, but then he had also some breaks in those the metatarsals. So this is an injury that you might see, but typically when we see like those ankle dislocations, they're rolled the other way, right? So it's kind of rolled in to where the outside of the ankle rolls out. Yeah, I'm sure most of you have seen a rolled ankle, right? It's a rolled ankle, the foot kind of tips in towards the center of the body, and the leg is on the outside. So this is kind of an opposite effect. Looks wrong in so many ways. Angulation is bone is misaligned. So there's that terminology. So angulation, bone is misaligned as a result of the injury. Non-displaced fracture is simply a crack of the bone. So you could have bone fractures and there's no displacement of that bone. We might see that with vertebrae. We might see that with arms. The first time I broke my arm, I had a non-displaced fracture of both the radius and the my radial and my ulna. Kind of just one of those things. A displaced fracture is when the two bone ends of the fracture are separated in at least one plane. So that's when we're going to either see like a angulation of the bone, or you might have that, like with a femur, it might be shortened up as it gets displaced and that muscle retracts that bone and those two ends pass each other. So the different types of fractures are important to understand because these are also terms that are going to come up in a test at some point. So you have your transverse, your oblique, the spiral, the comminuted, green stick, incomplete, the pathologic, and the epiphyseal. So the green stick and spiral are going to be the ones that we kind of see with pediatrics, especially the green stick. Signs and symptoms, obviously we're going to have some type of, we could have some type of deformity. Remember, sometimes we might have that fracture and there's no obvious deformity. There could be some shortening of that limb as those muscles contract back. You could have swelling. You can expect bruising, obviously tenderness. There will be pain. They could be guarding, and there could possibly be crepitus. Crepitus sometimes you may not hear initially. I know when I've checked for possible rib fractures, in order to actually hear I've heard crepitus when I auscultated with the stethoscope over that injured site. You could have false motion, which occurs at a point in the limb where there is no joint. That'd be like that lower one right there. Lock joint is difficult and painful to remove. I've seen this one too. That bone's just rolled out and ugh. In an open fracture, exposed bone ends may be visible in the wound. Now, dislocations. Bone is totally displaced from the joint. So this is more specific to an actual joint dislocation, not a fracture. May spontaneously undergo reduction. Subluxation, partial dislocation of a joint. So there's your subluxation. Remember that as a term as well. With these, obviously they're gonna experience some type of deformity. There's gonna be some swelling, pain, tenderness. They could be guarding it as well because of the pain. There could be a complete loss of normal motion as a result of that joint being dislocated. So that's a locked joint. They could also experience some numbness or impaired circulation to the limb or the digit, which is why we need to check CMS in those extremities when you have a obvious deformity. Ligaments are stretched when there's a sprain. So say like you could have a sprain of any joint where ligaments can get stretched or torn. You're going to have point tenderness, swelling, bruising, pain, and there's going to be possible instability with that as well. And the more that swells, the more stable the joint's going to be because it's not going to move. But when that joint gets checked, it's going to be notably an unstable joint. Sprains rarely involve deformity. So that's good to know. Strains, a little bit different than sprains, but a strain is when the injury to a muscle or tendon that stretches from violent muscle contraction or from excessive stretching. So it can be hyperflexed. Only minor swelling may be noted at that injury site, and that's because of the minor tears that could be exhibited from that strain. The joint has gone further than what it was supposed to go. Achilles tendon rupture, painful. Seems like I know somebody that could talk to that. Most immediate indications are pain from the heel to the calf and a sudden inability to perform a plantar flexion of the foot. So they are unable to flex that foot. They can't raise it at all. Acute management includes rice and pain control. That's not white rice, though. What does rice stand for? Rest, ice, compress, and elevate, right? Okay. So long-term treatment may involve splinting or even surgery of this. Amputations are a separation of a limb or other body part from the remainder of the body. Hemorrhage can be severe and life-threatening depending on what part is amputated. First amputated part that I saw was on, I think it was like a 4 or 5-year-old. Twins were playing around with the bike. The bicycle was upside down. I know I've done it 100 times as a kid. Had that bike upside down sitting on the seat and on the handlebars, and him and his brother were turning the pedals on that bike just as fast as they could, just to see how fast they could get that wheel spinning. Well, one of the kids put his finger too close to the sprocket, and it lopped off his finger at the joint. They could tell the kids apart now. Twins. The mom actually made that joke. Well, at least I can tell them apart at Christmas. All right. Good to know. Any questions on the mechanisms, fractures, dislocations, amputations, anything?
Go over the difference between the green stick and bending the feet.
Green stick is more of the bending, correct? Of like with pediatrics, and then it gives after a certain point. Is that right? I don't remember.
I know it's still just because with the bones being so soft, right? It bends, so it's like almost a complete fracture, from my understanding.
Okay, but there's going to be a fracture in that bone, right? So you're going to have that bend until a portion of that bone gives. Then you're going to get a fracture in it. So it could be non-displaced because it may not be a complete fracture. It doesn't bend because the bending force. It's a bent bone. From what I understand, I mean it's just taken a incomplete to that next. From my understanding, because the bone is actually bent. In pediatrics, infants, the bones are soft. Can be soft.
Does it stay bent? Is that what you're saying?
It sounds like in the book it's kind of the only difference it has is the angulation.
I saw the pictures, one longitudinal, but I didn't get that.
I've never experienced one. It's been a long time since I've read about it. Anybody online got any input on green stick?
It's the same as incomplete, but may still cause substantial angulation.
Jeff?
Yeah, I just looked it up. This is just like what you said. It sounds like it bends into the cracks, but there's a crack, there's a break. So it's a complete fracture, but it doesn't bend. Children under 10 years old, typical in it.
It's because the bones are still somewhat bendable.
Yeah.
So with that, that's a significant force on a pediatric's bone in order to cause a fracture. Cool. Anybody else? All right. So assessment. Obviously, there's going to be understanding the mechanism of injury. You're coming up on scene. You have a good grasp of the mechanism of injury based off dispatch information. You come on scene. You do your scene size up, scene safety, all that. You're getting a general impression of what's going on. You have a visualization of the actual injury. There's got to be some attempt to splint. And we know that most of our patients are going to be splinting themselves in some fashion, whether it's just not moving the extremity or the injured part of their body, or if they're actually holding it, guarding. They're in a way they're stabilizing themselves to an extent, but that's not always the case. We need to provide additional stabilization. Carefully assess that mechanism of injury. Remember, the golden hour is critical for some of these patients, not only maintaining life, but also preserving that limb as it correlates with circulation. Other priorities are identifying other injuries, all the injuries, prevent further harm or damage to the injured structure and surrounding tissues, support that injured area, and then consider administering pain medication if necessary. We also have wonderful ice packs that we can administer for pain management. They're not great, but at least it's something, because sometimes these patients, they at least need some type of, there's a psychological effect that ice pack can give. Okay, so it's doing something as opposed to doing nothing. That ice also can help constrict the vessels to help prevent further bleeding and further bruising. So you always have to have maintain a high index of suspicion for associated injuries to whatever the main issue is. Life-threatening injuries and only simple injury, musculoskeletal trauma. There's life or limb-threatening musculoskeletal trauma and no other life-threatening injuries. Or you could have an isolated non-life-threatening or non-limb-threatening injury. Any suspected open fracture or vascular injury is considered a medical emergency. There's a table 33-2 in your book that identifies critical injuries by using the musculoskeletal injury grading system. So just pay attention to that. I have no idea what that looks like. So, oh, there it is. So on page 1328. So you got your minor injuries, moderate injuries, serious, severe, and then your criticals. So that's just good information. Good information.
Too long bone is a priority 2 trauma alert too.
Yeah, so understanding our priority 1, priority 2, and priority 3 trauma activations, that's good. And the two long bone fractures, priority 2. So scene size up. Observe for hazards. We do that. Try to identify the mechanism of injury. You want to evaluate the need for additional resources like law enforcement for traffic control, additional hands for helping stabilize or move the patient, depending on the type of potential rescue that might be involved, or just the environment that you need to move that patient up and out of. You have to be alert for both the primary and secondary injury. Remember, you have the primary, don't let it suck you in, because that's the first thing you saw, and you don't go and find any secondary injuries. Your primary survey is going to be focused on the patient's mental status. Continue history taking and secondary assessment in case of non-life-threatening conditions. You want to identify the injuries and prevent further damage, of course, and then evaluate the patient's level of consciousness and their orientation to what's going on. Check for responsiveness using AVPU, the alert to verbal, alert to painful stimuli, or just unresponsive. You want to obviously administer oxygen as needed. We just don't go and put oxygen on everybody like we were taught back in EMT basic. Seems like everybody got oxygen. You want to consider taking spinal precautions. So, and we're good at that. At least maybe putting a collar on in specific situations, especially if they're unconscious. Then you want to, based on the mechanism, you want to assume that there could be a spinal injury. We want to put a collar on for just precaution's sake. You want to address any exsanguinating hemorrhage first, and then address airway and breathing. So gross hemorrhage. You want to address any of that first. Where is that blood coming from? Stop the bleed, and then address any other airway and breathing concerns. Move on to circulation. We're going to treat for shock by keeping that patient warm. Oxygen as needed, IV, large bore, and giving them fluid boluses. Obviously, if we're giving fluid boluses, we need to assess the lung sounds so that we don't flood the patient, but don't be scared of giving fluids. Just know what, why, and when. Careful handling all the extremities, minimizing carefully handling of the extremity minimizes this risk of maintaining a normal body temperature. If we compromise the circulation when we're moving that or stabilizing the extremity, that could cause body temperature changes in that extremity, right? So that CMS can be affected. Again, history taking, investigate the chief complaint, get a sample, OPQRST. You can modify this to what is going on. Don't forget that just because you're addressing a trauma, that they could have had some type of a medical emergency that put them into this trauma. So they could be experiencing a medical and a trauma situation. Just make sure that you do a good, thorough assessment. They may be experiencing acute pain with musculoskeletal injuries, or maybe this is just a chronic issue. So trying to identify, is this acute or is this chronic issue? What is different? If this is a chronic issue, what is different right now than what it was a week ago or last month? Secondary assessments is going to go and start with a full body scan, identifying any hidden or potential life threats. Obviously, we're checking for DCAP BTLS, cover the 6 P's of musculoskeletal assessment, evaluate the circulation, motor function, abnormal sensation. So you're checking that CMS in the extremity. Or multiple extremities if you're maybe dealing with a some type of spinal injury. Always evaluate the joint above and below the site of injury. The six P's. You're checking for pain, paralysis, paresthesias, pulselessness, pallor, and pressure. So those are your 6 P's. Assess the entire zone of the injury, not just the specific point that they're hurting, the entire injury. And make sure that it does include above and below, the joints above and below the site. You want to inspect for any deformities. Those skin changes, swelling, muscle spasms, abnormal limb positioning, decrease or an increased range of motion. You're noting the color changes in the skin, and you're noting the bleeding. What kind of bleeding is it? Is it just capillary bleeding? Is it just that oozing blood? Or is it free flowing? Is it flowing because it's a small vein, large vein? Or is it spurting now, and it's spurting because it's an artery? What size artery is actually bleeding? Is it an area that we can apply a tourniquet to stop the bleed if it's arterial? Or can I get away with just applying pressure? These things that you need to assess. Are your interventions that you did initially because of gross hemorrhage, did they stop the bleed, or do you still have excessive bleeding? You need to apply additional bandaging. The color changes, do I have an improvement, or is things getting worse? Muscle spasms obviously can be an issue. Other skin changes, things like that. So we always need to just reassess that area, reassess our interventions, making sure that our interventions are improving that overall patient's condition. Palpate for tenderness is we want to be cautious with this, obviously. We don't want to increase the pain in that patient, but we need to try to do a good thorough assessment. Does that pain increase when we palpate? Or was there no pain, and as you're palpating, you find pain? When you palpate of pelvis, making sure that if they are complaining of pelvic, or some patients say hip, but they really mean pelvis. A lot of people seem to get the pelvis and hip it's kind of intermingled. But if they have either a potential hip or pelvic pain, we want to be very ginger and tender when we're actually palpating that. We don't want to just reef on them and do that squeeze in and push down, especially if they end up having an open book fracture. That's could create additional damage to those vessels that are going through the pelvis. You want to independently palpate the entire length of each arm and leg to identify any sites of injury. Sometimes it's doing the kind of that opposite pushing in opposite directions to assess the stability of those limbs. Examine the cervical spine and shoulder. Do a good thorough assessment of those. Do not repeatedly examine the pelvis if instability is found. It would be bad. All right. Neurovascular status, you need to reassess every 5 to 10 minutes. You always recheck the before and after splinting, so we're always doing that. That's part of the skill sheet anyways. You want to check CMS prior and post. So before, as you go in and have somebody apply manual stabilization, you're going to assess CMS. And then once you have performed that stable, traction splint or SAM splint or vacuum splint, whatever, or sling and swath, you're going to reassess CMS to make sure that you did not create further damage. So the reason we're doing that is obviously if they have good CMS in the beginning and we go in sling and swath or apply a traction and all of a sudden now they don't have a pulse, that would be bad. Now we're making things worse. How are you going to mitigate that? Failure to restore circulation can lead to death of the limb. You always want to check vital signs. Depending on the severity of this patient's injuries, they're either critical or non-critical, right? So again, reevaluating vital signs every 5 minutes on critical and 10 to 15, I think probably the book says just 15 on non-critical. Repeat the primary assessment. Recheck interventions, stabilize ABCs, bleeding, C-spine, pelvis, extremities, make sure they're all secured. Reporting problems with ABCs, open fractures, and compromised circulation before and after splinting. So again, with these patients too, we want to try to communicate with the hospital depending on the severity of the injury. We got to keep that mindset of I need to make sure that I notify Kootenai as early as possible of the potential of this patient needing some type of surgery or some type of surgical intervention. Give complete descriptions of the injuries and the mechanism of injury in documentation. I talked about this last week. We have the ability of taking pictures of, say, vehicle crashes, to help give the doctors, the surgeons, a better indication, a better appreciation for what we pull these patients out of. Always document the CMS. We do a good job. I believe we do a good job of that. And when abnormality is identified, document the specific deficit. So if the patient has no life-threatening injuries, we can take a little extra time at the scene to stabilize the obvious injuries and perform a more thorough evaluation. So that's that stay and play. Obviously, if there is some type of life-threatening injuries, we need to pretty much load and go, do the best you can at stabilizing everything that you have to get stabilized, get them in the ambulance, and then do a good head to toe. Maybe get them trauma naked so you can get a good inspection of what's going on. Make sure you don't miss anything. Any questions on primary, secondary stuff that we repeat every chapter? Okay. Online, you guys still with me? Grazie. Oh. All right. Ruber. That's a Ruber yelling. All right. Let's move on to emergency medical care. Get through a little bit of this, and then we'll try to take a break. So first steps include the primary survey and the stabilizing the patient's ABCs. And before we even get to ABCs, we need to make sure that we're identifying life threats, that gross hemorrhage. Perform a rapid full body scan and focus on the specific injury. Don't get drawn in and sucked in on injuries that can distract you from finding the life threats. Always take standard precautions. Be alert for signs and symptoms of internal bleeding. With this, we're taking in consideration that the golden hour, right? The platinum 10, being on scene for only 10 minutes. Volume deficit is due to musculoskeletal injuries. Fractures may lead to significant blood loss. Why? Why is there a significant blood loss in bone, say, bone fracture? What's inside of the bone? Marrow. Okay. What is it? What large blood vessels are going through the bone? What's the bone making? Red blood cells. Okay. So there's a lot of blood going through that, right? Okay. So we need to be aware of that. Keep the fluid volume, vital signs, and mental status normal. We're trying to keep that body in a homeostasis state. Administering fluids at 20 milliliters per kilogram. Increments to maintain blood pressure and perfusion. Now, there's your fluid bolus. Except I would not expect you to just say, okay, I've got a 100 kilo patient, and I'm going to give them 2 liters of fluid to maintain blood pressure. I'm just going to flood them with 2 liters right now. Well, again, understand how fast you're going to be able to get that 2 liters in. How quick are you going, or how often are you going to reassess this patient? You know, am I reassessing after each maybe 400, 500 liters I get in there? It all depends, right? It depends on how fast you're getting that fluid in. It depends on your catheter size and your drip set on how fast you're going to be able to get those fluids in. So just take all, I mean, it's a lot of stuff to take into consideration. But understand why you're giving the fluids. What pressure are we trying to get? We're trying to get that 90 systolic, right? Overall, we're trying to get that mean arterial pressure up to 65. That's that diastolic times 2 plus the systolic divided by 3. That's how you find that mean arterial pressure. Diastolic times 2 plus the systolic divided by 3. We're trying to get that mean arterial pressure at 65 so that we can maintain good organ perfusion. We're trying to preserve those organs, make sure that they're functioning. Cold packs are used for treating patients during the initial 48 hours following an injury. You want to try to constrict those vessels. Slow the swelling down. Heat therapy should be avoided during the initial 48 to 72 hours. If you have heat therapy, what is it going to do to those vessels? It's going to dilate them, right? And you're going to get blood flow. That's why, especially in like, say, lower back injuries, I've people who have those acute lower back injuries, especially, it seems like, you know, the old mentality was, yeah, ice and then heat, ice and heat, and you just alternate. But in that, you got to make sure that within those first 72 hours, you truly want to try to avoid heat because things are swelling up, they're tightening up. You want to avoid that rush of blood into those that location, that injured site, to prevent further swelling and irritation. So that cold is going to decrease the release of inflammatory mediators. Okay, the heat, that's going to go going to go well with, say, like ibuprofen or Toradol, those anti-inflammatory medications. Splinting. When no splinting materials are available, use the patient's own arm. They're going to be holding it a lot of the times anyways. And then that arm can be bound to the chest. An injured leg can be bound to the uninjured leg. You know, it's one of the things that I've seen that we've done or even talked about in skills is that if you have a possible leg fracture, if you're putting this patient on a backboard, you're securing pad around, and there's no need another type of traction or splinting device on that lower leg if you already have it onto, say, a backboard. The different types of splinting materials or devices, you have the traction, you have rigid, and you have formable. The best way to stabilize multiple fractures is by splinting axial skeleton using a longboard or straps or an alternative device. Longboard and straps or an alternative device. So we have the short boards and we have the KED. Principles of splinting is to remove the clothing from the area of any suspected fractured or dislocation, because you really want to be able to get good eyes on, see what's going on. You want to assess and record the patient's neurovascular status distal to the site, so that's that CMS. And you want to cover the wound with a dry sterile dressing if you have bleeding or an open, some type of an open wound. You want to try to cover it with dry sterile dressing. Do not remove the patient, or do not move the patient before splinting an extremity unless there is an immediate hazard to the patient. We want to try to, again, prevent further damage by moving them, and you're going to maybe get that crepitus or further tears in their ligaments, their tendons. Pad all rigid splints to prevent local pressure and discomfort to the patient. If a long bone fracture is severely angulated and no pulse is present to the extremity, gently apply longitudinal traction. So you're going to kind of pull on it to try to pull some action to relieve some pressure off of whatever vessel is occluded. That should hopefully allow the circulation to continue, and make sure that you document this. If the patient reports severe pain or is resistant to the movement, discontinue, obviously, applying traction and splint the joint as it is in the deformity position that it is currently in. So you're just going to splint as it is. When in doubt, splint it out. We want to avoid covering the fingers and toes with splints. When it comes to hands, make sure that you try to keep the hand in the normal, natural position. That's why we put like a padding, let's say a rolled gauze, up into the hand to try to keep it in its natural position. Apply cold packs. Make sure we're still doing cold packs. Again, I think this is a skill that it is commonly missed. It is commonly missed. I'm not perfect. I miss it once in a while, and we go straight to medications, right? But make sure that we're giving some type of cold packs to an injured site like this for the reasons of trying to reduce the swelling and also helps improve their pain. Hazards associated to improper application of a splint can be compression of the nerves, tissues, and blood vessels, delay in transport of a patient with life-threatening injuries, reduction of a distal circulation, aggravation of the injury, or injuries to the tissue, nerves, blood vessels, or muscles due to excessive movements of the bone or the joint. Traction splints are the most effective way to realign a fracture of the shaft of the long bone. You want to prevent that broken bone ends from overriding due to unopposed muscle contraction. Okay, otherwise it's going to could cause continued damage. You can start chipping away bone, cutting vessels, things like that. Reduce blood loss with splint. Let's see. Yeah, you can use the splint for helping reduce blood loss. Excessive traction can be harmful, though. Do not attempt to reduce the fracture or force all the bone fragments back into alignment. Don't try to just, well, that's wrong. Let me get it right in its right position. That may be bad. You may cause further damage. The goals of inline traction are going to be to stabilize the fracture fragments to prevent excessive movement. You want to align the limb sufficiently to allow it to be placed in a splint, and then avoid potential neurovascular compromise. Use the least amount of force necessary to accomplish this. Traction splints are used primarily to stabilize isolated fractures of the mid-shaft femur. So we have which device? What is the device we're using for mid-shaft femurs? Huh? Okay, there's Sager, and what else? What are the ambulances carrying? Online, what's the ambulance carry for mid-shaft femur? Come on. SAM splint is not necessarily for mid-shaft femur. It is a rigid device, right, that we want to use for splinting. The Kendrick, correct. So Kendrick is the device that we carry. There you go, Coulter. Kendrick is the device that we use for mid-shaft femurs. That's on the ambulance. That's what we're carrying on the ambulances. Okay, it's provided by the system. Again, that device is specific for mid-shaft femur. How are you going to know it's a mid-shaft femur if you don't open up the pants or the clothing to get a good eyes on, right? You got to have those eyes on. Do not use traction splints with injuries that are close to or involve the knee. Okay, so that's a contraindication, right? Injuries to the pelvis, partial amputations or avulsions with bone separation, or lower leg, foot, or ankle injuries. So those are your contraindications for that traction splint. Hair traction splint, there's the Sager traction splint and the Kendrick. So those are the three big ones that are out there. Rigid splints made from firm material and are applied to the sides, front, and or back of an injured extremity. Typically, it takes at least 2 people to apply a rigid splint. So for this, we have our SAM, right? Our SAM splint material. That SAM splint material can be, we have a couple different sizes, I believe. You're going to find those either folded in packages or you're going to find it in a roll. Those SAM splints can actually be cut relatively easily with the trauma shears, so you can cut to what you need. It's pretty easy to mold, and then with that you want to wrap it with some type of rolled gauze to try to keep it in place. You must splint the limb in the position of the deformity when the deformity is severe. Resistance or extreme pain is encountered when applying gentle traction to the fracture. You always want to try to apply some padding around the board to each side of the limb and secure them with soft roller bandages. Another consideration, especially with open injuries, is maybe put a chucks within that to help control with containing some of that blood instead of getting that blood everywhere. Even with minor, I mean, so we don't always put bandages, I mean, direct pressure and wrap every single injury. If I have a traction splint and it's just minor capillary bleeding, some minor venous blood due to a laceration or you know, a pretty good abrasion, I might just put a bandage, or I may not use a chucks necessarily, obviously that's, but some type of a sterile dressing, and then put the traction splint or the SAM splint over the top of that in order to keep pressure. So it says, the book says that most dislocations should be splinted as found. That'll probably come up as a test question. I don't know for sure. Just saying. Pneumatic splints. We don't. Yeah, so air splints. So we have the vacuum splints. We still use those. Useful for stabilizing fractures involving the lower leg or forearm. Can also be good for, say, knee dislocations. Air splints always air splints, it says always inflate after applying it. For us, we're pulling air. We're using vacuum splints. So there's the 2 different types. There's the air splints and there's vacuum splints. So I don't believe anybody has any air splints locally, but we utilize vacuum splints, and with that we want to deflate. We want to pull as much air out as possible to make that device rigid. It says all open wounds must be covered with a dressing. Carefully monitor the splint, and with the air splint, let out air if it becomes overinflated. We don't use pneumatic anti-shock garments locally. There's a chance that this might actually come back, but I'm just going to pass it. Formable splints include vacuum splints, pillow splints, structural aluminum malleable splints. So those are your, I guess technically it's not a rigid splint. So SAM is not technically rigid. It's considered a formable splint, along with our vacuum splints. Sling and swath, and the pelvic binder. Vacuum splint can be easily shaped to fit around a deformed limb. It seems like I've used those a lot for dislocated ankles and knees. It seems like those are the ones I've used the most for the vacuum splints. Pelvic binder provides temporary stabilization. Should be light, made of soft material, and easily applied by one person. This is still going to hurt that patient when it's applied, so you got to be cautious applying it. As you try to get this up underneath the patient, you don't want to be jarring them back and forth as you're trying to seesaw it back and forth underneath the patient. Utilizing extra set of hands to help stabilize or even lift that patient up a little bit to get that binder underneath would be helpful. So buddy splinting is used to splint injuries involving 2 fingers or toes. Involve multiple fingers or toes. Tape the injured digit to the uninjured one. That's pretty simple. Transports, obviously you want to transport with the pulse. A patient with a pulseless limb must be given a higher priority. So this patient might be a code response to the hospital, a code transport. If circulation in a distal limb is impaired, consult medical direction. So obviously we want to notify the hospital as quickly as possible, let them know what's going on so that they can try to get some interventions ready by the time we get there. Any questions then on this last section for emergency medical care? Online? Questions? Coulter? Matt? Anybody else? As we get started back into this, formable transport, here we go. So transportation, a patient with pulseless limb must be given higher, yeah, we talked about that. I talked about that, sure. All right, get into some pathophys assessment management complications of some of these injuries. So often these are related to the strength of a force that caused the injury or injury location of the overall health as a result of possible infection, long-term disability, pain. Do some stuff here. All right. That's good to know. Maybe we'll talk about that, Church. I appreciate that. We'll have to square that away. I mean, if that's going in some blood tubes, that's fine. Or whatever. All right. So peripheral nerve and vascular injuries. When blood vessels are damaged following a musculoskeletal injury, you could have some devascularization that may occur. So displaced fracture fragments may lacerate or impale the surrounding nerves. And you could have neurovascular injuries that are also likely to occur following a joint dislocation. So as the joint dislocates, it can pinch a nerve or damage those neurovascular the nerves in that area, or even the vasculature in that area. It's important to assess and reassess the pulse, control bleeding, and maintain adequate intravascular volume. So compartment syndrome is often when fractures have open fractures have a high risk of compartment syndrome, usually that develops within 6 to 12 hours after the injury. You know, the longer that it persists, the greater the chance for tissue to develop necrosis. So the tissue is going to start dying. It's characterized by the severe pain in that affected area. You're going to have skin pallor. You're going to have some numbness, and you could have the absence of distal pulses. And that last one, so the absence of distal pulses is a late sign for the compartment syndrome. So late sign. If the patient has a fracture below the elbow or the knee, ask about the following. You want to find out about what's their pain. Scale of 1 to 10, 10 being the worst pain. You know, what does it feel like? Is it sharp? Is it dull? Find out about it. Decreased pain sensation. You want to find out if there's any pain on stretching of affected muscles, and if they have any decreased strength in that location. So any weakness. Management should include elevating that extremity to the heart level, trying to prevent some of that throbbing effect and maybe some of that swelling. Probably just get improvement on pain. Placing an ice pack over the extremity. Opening or loosening constrictive clothing or splinting material. You want to administer oxygen. Consider administering oxygen. Give IV bolus as needed. Consider, well, we don't have NOS. But again, make sure that they have ice packs and possibly get a medic involved for further pain management. Frequently reassess the CMS of that limb or that area. Crush syndrome occurs following the extrication or release of an entrapped limb. So that looks bad. Rhabdomyolysis can occur from the crush syndrome, and that is you have that buildup of lactic acid, right? So the muscles continue to metabolize. You're going to have that buildup of lactic acid, and this could kill the surrounding tissue, distal tissue. Also, with the release of that crush injury could induce a cardiac event. So making sure that you possibly monitoring that patient's vital signs, their heart rate, their electrical activity would be important with this. Continually reassessing ABCs, CMS, supplemental oxygen as needed for this injury. Again, with IV fluids. So the book says that after a muscle is compressed for 4 to 6 hours, the muscle cells begin to die and release their contents into the localized vasculature. So that's important to remember. That's what the book says. It's compressed for 4 to 6 hours. You know, I used to be taught that it was, you know, after 3 hours, you have that issue of crush syndrome can start occurring. So just make sure that if you were going off that old information, just go off what the book is talking about. Rhabdomyolysis. again, it's going to be harmful. Thromboembolic disease is signs and symptoms of DVT. So this is your DVT. Disproportionate swelling of an extremity. They're going to have extreme, just like a discomfort. They could have pain. It's going to be worse on that affected extremity. The temperature is going to be different. That extremity is going to be not only swollen, but it's going to should be red and swollen. It's going to look possibly flush, and it's going to be very warm. Okay, because you're getting that backup. The circulation is affected. This can be a very serious thing. We want to be very careful with these patients, because when a DVT dislodges, it may cause a pulmonary embolism, and this, I mean, it could be potentially fatal for this patient. Some of the other signs and symptoms: sudden onset of dyspnea for the PE, pleuritic chest pain, so tachypnea tachycardia, so that rapid heart, rapid breathing. They could have right-sided heart failure. They could be in shock. They could exhibit signs of shock, and they could eventually go into cardiac arrest. This can be very sudden as far as the cardiac arrest, and we're just going to do work as normal, right? Just do crushed chest and go through that algorithm. Patients with long bone or pelvic fractures are the ones that are at risk for developing the fat embolism syndrome. We might experience this with patients who just had some type of a surgery, who have sedentary lifestyles, or have other complications and had been down for a long time, say because of maybe travel. You want to make sure that you treat this patient's ABCs. That's important. Try to get the IV, give them some fluids, and rapid transport and notification to the ED. Scapula and clavicle injuries, going to be pain in the shoulder. Patient will usually hold their arm across the body. So again, they're kind of guarding, they're splinting themselves, trying to prevent further injury, trying to reduce some of that pain. Young children often report pain throughout the arm and are unwilling to use any part of the injured limb. So they just might, well, can you move your fingers? No, I can't. It just hurts. So I mean, you may get, and not necessarily children. I've seen this with some other patients, older patients, that just don't want to move anything because they're afraid that it's going to cause additional pain, even though they might be able to move it without any further pain. Scapula is a very hard bone to break based on the way it's designed. So an injury to the scapula usually is a result of a pretty significant mechanism. Other things that you might see with these type of injuries are going to be, let's see, maybe it comes into the next slide, I'm not sure. I'll get to that. So tenting, you might see tenting with that, with the clavicle, and that's the bone as it's displaced is pushing up against the skin. You're going to see that skin is going to be white. It's not really getting it's not really getting any circulation at that very point, which actually can be very dangerous. That could cause necrosis of that individual point. You're going to have swelling, point tenderness. You could also have a drop shoulder. So that one side is significant. It's dropped down as that person is standing there. It looks like it's just dropped down to one side. These injuries could also occur as a result of crushing injury to the chest. So a lot of clavicle injuries happen as a result of arms being stretched out when somebody falls forward or dives. Snowboarding injuries, skiing injuries, when you have that arms outstretched, and it ends up has a great potential for breaking that clavicle. The scapula, like I said, it's usually as a result of violent direct trauma to the back directly over the scapula. You want to carefully assess the patient for signs of pneumothorax, because if they had a significant amount of trauma to that scapula, they potentially have some underlying damage below that to the ribs or even into their thoracic cavity. So you're checking for lung sounds, making sure lung sounds are present and equal on both sides. They've got good chest rise and fall. These patients, because of the pain, probably are not going to be taking deep breaths. So if you go and try to ask them to take a deep breath, they probably won't, as a result of increased pain from the movement of that deep breath. So you might experience this patient having short, rapid respirations just as a result of the pain. Or it could be slow respirations, and it's just like, say, a long expiratory phase. They get that breath in, and it's just a long grunting expiratory phase because of the pain. AC joint between the lateral aspect of the clavicle and the acromion process of the scapula. So that's that point, like in this picture is showing right there. It's an actual joint. Dislocation is called the AC separation, and patients will report pain. And again, this is a similar injury mechanism as with the clavicle. It could be with the patients that have the arms that are outstretched. Management is pretty basic. You might splint the arm to the body just to prevent movement, because this is going to have extreme pain up into that shoulder region, and any movement of that shoulder is going to increase pain. Fractures of the clavicle and scapula and AC separations can be effectively splinted, as it shows here, sling and swath. Moving on to the shoulder, glenohumeral joint, where the head of the humerus meets the glenoid fossa of the scapula. So that's the glenohumeral joint. The humeral head most commonly dislocates anteriorly, so it will come forward. Okay, and you might experience this with a drop shoulder as well as you're looking at this patient. It's just going to kind of be anterior, and it possibly will be kind of drop down. Patient will be guarding, potentially holding their own, basically splinting themselves with the other good arm, trying to protect it. The humeral head will protrude anteriorly underneath the pectoralis major and the anterior chest wall. Some patients may report numbness in the hand because of the compromise of the nerves as they're going through that joint, and that with that dislocation, they might have some numbness because it's the bones are pinching on those nerves. Or even the circulation that might be compressing against some of those vessels that go through that joint. Stabilizing, again, sling and swath. You might have to put extra padding underneath the arm, between the arm and the body, in order to, because of positioning. So I think with this, they might have a pillow. If you've seen anybody who has had shoulder surgery, they have that sling, and then there's that extra pad that goes underneath, trying to keep it's a more neutral position for that shoulder joint. Dislocation of the shoulder disrupts the supporting ligaments of anterior aspect of the shoulder. So dislocation recurs because these ligaments often fail to heal properly. Some patients can reduce their own dislocated shoulders. If you've ever seen Lethal Weapon, he does that. Riggs, he does that in the movie, I think, in all 20 of those Lethal Weapons. It's good series. I wouldn't suggest instructing your patient to do that if they've never done that before. That's the movies. All right, fractures of the humerus. It's not funny. It's just a fracture. The proximal humerus is typically from falls and are most common among older patients. Why? Because Decreased bone density, that osteoporosis setting in, right? Midshaft fractures occur more often in younger patients, usually as a result of violent injury. So, those awesome BMX jumps or hockey getting slammed up against the wall or football. Radial nerve may be injured. It's a classic sign of radial nerve injury in the wrist, and you're going to see it like that wrist drop. If the fracture is angulated, you want to try to provide some traction to try to correct the deformity, maybe, or splint it in place. Once the extremity is in the desired position, apply a rigid splint that extends from the axilla to the elbow. So as the picture shows here, a good way of splinting that is applying, so for us, we'd have that maybe a SAM splint, kind of wrap it around the back of the arm, the side of the arm there, the lateral aspect, go from the top all the way down and maybe even wrap underneath the elbow to provide some stability as you wrap it up with the slant swath. Elbow injuries. You want to assess the distal pulse, apply 2-padded board, splints to each side of the limb, secure with a soft roller bandage. Mold a padded wire ladder splint or SAM splint to the shape of the limb. So, again, I think the best picture for us with this is going to be that lower one where it shows the SAM splint being kind of molded and then wrapped. And as you can see, the end of this where the hand is, they have that kind of rolled over to apply a natural form for that hand, kind of that neutral position for the hand. The important thing with that is, and why that will come up, is if you leave that hand in an abnormal position, it potentially can have spasms. You can have muscle spasms of the hand as it tries to retract if it stays in an abnormal position for too long. Cold, pale hand or a weak or absent pulse or poor capillary refill indicates that blood vessels may have likely been injured. We want to obviously try to document that. We want to apply general manual traction to that extremity with the long axis of the limb. So try to relieve some pressure to decrease that deformity. And that's really only if we're getting that poor CMS, right? So any questions beyond that, you need to contact medical control. Fractures of the forearm is going to be a fracture of the radial and or the ulna, and are common in people of all ages. You're going to find this in patients of different types of crashes, falls. Usually it's because of the outstretched hands again. So if they fall and they don't, maybe they did break the radial ulna and they could have dislocated AC. So both bones break at the same time when the injury is the result of a fall. Isolated fracture of the shaft of the ulna may occur as a result of a direct blow to it. So it's considered a nightstick fracture. So the ulna, right, is this side of the arm. So nightstick fracture, somebody gets whacked with a nightstick. They put their arms up to defend themselves. They get a nightstick up against the ulna, causing that fracture. They should have listened. Fracture of the distal radius, known as the Colles Fracture, the Colles Fracture, is a silver fork. You can have a silver fork deformity. It's distinctive appearance of the patient's forearm. So it's kind of got that little roll to it. That's a silver fork deformity. So it's very, it's pretty specific. In children, this fracture may occur when the growth plate occur through a growth plate and can have long-term consequences. Remember, with kids, if they have any damage to that growth plate, it's going to affect or potentially affect their long-term growth of that bone. So they could have lifelong deformity. Maybe it doesn't grow, maybe it stops growing as a result of that injury. To stabilize the fracture, you want to use padded board, use a vacuum splint. Those are what we have. If the shaft of the bone has been fractured, include the elbow joint in the splint. So remember, when we're splinting a fracture, we want to try to isolate the joints above and below that fracture. Splinting of the elbow joint is not essential with fractures near the wrist. Usually with that, if it's near the wrist, you can get away with just splinting from, say, mid-forearm all the way forward. So these injuries have to be confirmed with X-ray. Isolated non-displaced fractures of a carpal bone is common. Hand injuries are widely, and some have hand injuries vary widely, and they have some potential for serious consequences. You know, for our field, I mean, we use our hands for everything, right? If we had a disability injury to our hand or our wrist, that could truly affect us being able to perform our specific job. May not be able to limit you from taking a desk job, or white shift, but obviously it could definitely affect us long-term for our job. You want to always take any amputated parts to the hospital with the patient. Like I said earlier with that the kid that lost the tip of his finger, his mom had the tip already in a little Ziploc snack bag ready for us to take. That poor little digit was so small, though, that it was a lost cause. But that's not up to us. That's up to the surgeon to figure that kind of stuff out. Let's see, a couple other things here. All hand injuries must be evaluated promptly by the physician. Do not attempt to pop a dislocated finger back in place. Do not. So pay attention to the book for that. All right. Onward and upward to pelvic fractures. They're responsible for a significant number of deaths as a result of blunt trauma to the patients. It can affect a number of structures within the pelvis, and there's a serious risk for injury when the pelvis is actually fractured. May be accompanied by life-threatening loss of blood. The pelvis is going to hold a lot of blood, and we're not going to see it. The patient that has a lot of blood buildup may have, as that pressure increases, they may give you some signs or some symptoms of feeling like they feel bloated, extreme pressure on say their bladder or even into their rectum. So the risk of injury within that area, the book talks about bladder, obviously, urethra, the rectum, vagina, sacral nerves, the sacral nerve plexus, veins within the pelvis, arteries, even into the lumbar region, nerves in the lumbar and sacral regions, and the sciatic and femoral nerves. So those are all the areas that talks about our potential have risk injury when there's a fractured pelvis. So, there's a substantial amount of blood loss. Often there are no visible signs of bleeding until severe blood loss has occurred. So, like I said, that patient's going to give you some type of symptoms, but you may not get those symptoms from the patient. You might only see that when you start doing the vital signs. So their heart rate increase, the blood pressure decreases, things like that. May also be there may be some bruising or lacerations in the perineum, the scrotum, the groin, suprapubic region, or even into the flank. They could have bloody urine, or they might even have blood coming from the other nether regions. Lateral compression pelvic ring disruptions result from an impact on the side of the body. So this could be like, say, your T-bone accidents, the high impact when you get, say, greater than 12 inches of intrusion into the passenger compartment. The side that sustains the impact becomes internally rotated around the sacrum. The patient could have profound shock, gross pelvic instability, diffuse pelvic and lower abdominal pain. They may also have bruising or lacerations, like I said, in the nether regions there. When they have some of those the pelvic fractures. All right. Anterior posterior compression pelvic ring disruption may occur following head-on MVC, motorcycle crash, falls, or a ped versus vehicle. So there's a good x-ray. Looks painful. Causes, let's see. So you have force of impact compresses the pelvis in anterior to posterior direction. Causes pubic symphysis and posterior supporting ligaments to tear apart. Pelvis then spreads apart and opens like a book. So then you get that open book pelvic fracture. Vertical shear, major force is applied to the pelvis from above and below. Patient is likely to have significant shortening of a limb on the affected side, and they have a huge risk for massive hemorrhage into the pelvis. This leads to a complete displacement of one or both sides of the pelvis toward that head of the femur. Oh wait, toward the head. I'm sorry, that's just toward the head. Yeah. So okay, so yeah, this is say if you have that patient who has a long fall and they land on their legs and that force is applied, they come to that sudden stop and that force is applied from the legs all the way towards the head, basically. There you go. Straddle fracture occurs when the fall after a fall when person lands in the region of the perineum and sustains bilateral fractures of the inferior and superior rami. Rammed it. So that's straddle fracture. Does not interfere with weight bearing with this. But carries risk because of associated complications. Open pelvic fractures present as presence of laceration of skin in pelvic region, vagina, or rectum, caused by a high velocity injury with subsequent massive hemorrhage. Massive. Life-threatening, it could be a life-threatening injury. It's uncommon, so you got that going for you. Even small amounts of blood found during vaginal or rectum exams should raise your suspicion of an open fracture. Good to know. So care with the pelvic fracture. Most reliable sign is simple tenderness on firm compression and palpation. So this picture kind of shows an example of how to assess the pelvis. And if they're having some pain in that pelvis, you want to be very careful. Be very gentle as you apply this pressure during your assessment. Do it slowly. Do it docilely. So the deformity or swelling may be difficult to see. If they're having some tenderness, again, you want to have a high suspicion. Be slow to palpate and make sure you try to use some firm pressure, but be cautious. As soon as they start exhibiting more pain, you want to release, preventing further damage. With injury to the bladder or urethra, you want lower abdominal tenderness and blood in the urine or blood in the urethra opening may be present. So they might be pee and blood. You want to perform a primary survey, of course, treat any massive hemorrhage, monitor ABCs, apply spinal immobilization as needed, at least consider it. Large bore IVs for fluid replacement and trying to maintain a good BP. And management involves reducing the amount of bleeding and decreased degree of instability. So we're going to basically try to stabilize the best we can and try to provide some type of bleeding control. Seek medical direction, especially to determine how to best stabilize the pelvis. We utilize the pelvic binder. If you don't have a pelvic binder, you can utilize a sheet wrapped around and then tie like a square knot over the top and to apply some pressure. That patient possibly will give you an indication that that feels better. And then try to stabilize it and keep it in that position. Apply padding on the sides as well as additional padding, and then gently move and transport. Utilizing a long board, this patient, maybe it's best to move this patient onto a soft board. IV fluids, avoid hypertension. Most dislocations of the hip are posterior. So femoral head is displaced posteriorly to lie in muscle of the buttocks. You want to suspect hip dislocation in a patient who has been in an MVC and has a contusion, laceration, or obvious fracture in the knee region. So this basically is popping that bone out of the joint. Femoral head rarely dislocates anteriorly. Legs are suddenly and forcibly spread wide apart and locked in this position. Posterior dislocation of the hip is frequently complicated by injury to the sciatic nerve. So they're going to have extreme pain or potentially have extreme pain as a result of that nerve. You may see the foot drop. So they don't have much control over that foot. And also with that nerve, that sciatic, they could have numbness into the side of their leg in the affected side, along the back of the calf, kind of the side of the calf, and into the outside, the lateral side of the foot, all the way up into, say, the lateral 2 digits of the foot. So that'd be like 4 and 5 foot digits. Patients with these posterior dislocation of the hip typically lie with hip joint flexed. So as you see the patient here, Yeah, so and this could be the position you find for either the dislocation of a hip or even a fracture of the hip. And this is actually the kind of the position that when my mom fractured her hip, this is the position that she was in, and she was just laying there, agonizing pain, holding that hip, not wanting to move due to that pain. You know, I'm sure most of us have been on those scenes where patients are in this kind of the same position, whether it's a hip dislocation or a hip fracture. They're kind of in this not wanting to move because it's so much pain. This patient might exhibit pain from not only from the outside, they might actually have pain that's specific more to the inside of the thigh and actually up into the groin. Thigh rotated inward toward midline of the body over the top of opposite thigh. So you see this picture in both pictures here. So it's kind of how that foot is. That foot is kind of, and the affected side is kind of dropped down. It's rotated inward, pointing towards the other leg. Distinctive signs: severe hip pain, strong resistance of any type of movement to that joint. They don't even want you touching it. Don't freaking touch it, right? Lateral and posterior aspects of the hip region will be tender on palpation, so just even touching the skin might actually bother them. Again, check for the sciatic nerve injury, assess sensation and motor function in the lower extremity. Like I said, that nerve, I've had sciatic nerve issues. I've had a bulge disc herniation and affect that sciatic nerve, and I had nerve numbness, like I said, in that lateral calf all the way into the top of the foot on the outside into that fourth and fifth digit. So that's that little toe and the one next to it. Do not attempt to reduce the dislocation, because truly you don't know if this is dislocated or if it's actually fractured. Okay. Place the patient supine on a scoop stretcher or on a long backboard. Support the affected limb with pillows and rolled blankets. This patient we might want to actually treat with either some type of procedural sedation or pain management before we even move them. Secure the entire limb to the backboard with long straps so that the hip region will not move, and then provide rapid transport to the closest appropriate facility. Questions on pelvis or hip? Super. Proximal femur fracture, usually called a hip fracture. Rarely involve the hip joint. Often occurs in older patients, especially those with osteoporosis. High energy injuries in young. So if it's going to be for younger patients, it's going to involve high energy. Leg is extended, rotated, and shorter than uninjured limb. So there's a good picture of what that potentially would look like. Is usually tender on palpation, gently rolled. Rolling of the leg will cause pain. So even putting them onto the board like that second picture possibly will cause them extreme pain. Assess the pelvis for any soft tissue injuries, bandage as appropriate. Again, checking CMS. After assessments, point the lower extremity. The age and severity of the injury, the age of the patient and the severity of the injury will dictate how to splint that fracture. Let's see here. Seems like I had something else to add to that. They might have significant blood loss with this injury as a result of the fracture. Again, the femur is a large bone, and you could have significant blood loss from the fracture of that bone. Moving on down to the femoral shaft. Can occur in any part of the shaft. Muscle spasms will produce significant deformity and shortening. Significant. Okay, that your muscles in the leg typically are large muscles, and they are going to retract that leg back if it is completely displaced. Patients often experience significant blood loss again, and covering any wound with a dry, sterile dressing is important if it's if there's some type of an open wound. This, with that muscle spasm, again with the mid-shaft femur, this is why we're applying the Kendrick or the Sager to try to provide some type of relief for that patient, as well as stabilizing and preventing continued damage. If the foot or leg is below the level of the fracture, let's see, if foot or leg below the level of fracture shows signs of impaired circulation, apply gentle traction to the limb in line with the long axis of the limb. So that's like when we apply traction, manual traction before we apply, say, the Sager, or even if we decide to apply manual traction before the applying the Kendrick. Gradually turn the leg from the deformed position to restore the limb's overall alignment. So you're trying to realign. The downside of this is if you get it realigned, you have it set back in place, and all of a sudden you get a muscle spasm. That muscle retracts it back. That's going to cause a little crepitus and grinding as the bones grind back and retract. You want to monitor for shock. Continue to monitor for shock, because this patient can lose, with that femur fracture, 1,500 cc's of fluid into the leg. Full spinal immobilization may be necessary. And it might be appropriate only to stabilize this leg to the good leg on a long backboard. You want to establish good vascular access and rapid transport. I feel like I got something in my nose. Something's crawling on me. So knee injuries, different types of injuries occur in this region. You could have ligament injuries, patella dislocation, or even a fracture. You need to make sure you do a good assessment of the knee to reveal any significant findings. Is that knee in line? Or is that patella over onto the side of the leg? And then you're looking at it and be like, well, there's your problem right there. Assess the patient's knee to reveal the significant findings. So you're going to cut the pants away, cut the boots off, whatever it needs to be done in order to get a good visual on that knee. Injuries of the knee ligaments. The ligaments on the medial side are the most frequently injured. So medial side is the inside, right? Dislocation of the knee. Ligaments may be damaged or torn. The anterior and posterior ligaments are commonly damaged. Posterior dislocations, a direct blow to the knee forces the tibia to shift posteriorly. There's a good video of that when a guy is doing a leg press and he locks up his knee and his knee dislocates posteriorly. That one's a difficult one to watch, right? Medial dislocations result from a direct blow to the lateral part of the leg. So you might see these, as a person, say, running and pivoting wrong as they make that step, or it could be like, say, a football injury, soccer injury, when somebody gets hit on extension and as they plant that leg. If adequate distal pulse is present, splint the knee in the position you find it in. Okay. Most of the time, this is going to be the case. And then promptly transport. Fractures about the knee, you might produce significant deformity that makes it look like a dislocation. So you could have this swelling that makes it look like things just ain't right. If the patient has a good distal pulse, splint it in the extremity, splint the extremity in the position found, apply. Maybe elevate the leg to the heart level to reduce some of that throbbing. And continue to monitor the distal neurovascular functions en route to the hospital. So we're going to continue to monitor what's going on. Are there any changes? That is a good, yeah. Patellar tendon rupture would be bad, right? That's a bad rupture. That's off the leg for a while. Surgery, I'm sure, right? Yeah. Long and painful recovery. That 13 weeks off of it before you could even start PT. Is that right? Maybe. Yeah, no bidding for. So yeah, ouch. Thanks, Matt. Dislocations of the patella, which could produce that, end up with that ruptured tendon. Minor twisting may be enough to produce the problem. Displacement of the patella produces a significant deformity in which the knee is held in a slightly flexed position. That's all kinds of ow. That's all kinds of ow. Again, with this, we want to try to just splint in place unless there is significant. If there's no CMS, then follow local protocol, contact medical control, transports rapidly, and all that. All right, let's take another break, and then we'll finish this out. If you have any questions online, just shoot them to me, and then we'll address them when we come back. All right, welcome back, and onward to the lower leg. So injuries of the tib-fib can look amazing, as you see in these pictures here. Fracture of the tib-fib may occur at or any place the bone there between the knee joints. Usually both bones fracture at the same time, and open fractures of the tib-fib are common. I see they could be isolated to, like I said, with one bone. It's uncommon, but with that, some of those ankle dislocations, if that ankle dislocates to the like the foot goes to the outside, goes laterally, you might actually have only a fibular break as it relates to the structure, how it comes down to the ankle. Stabilize the padding. Use a long, rigid leg splint or an air splint for these. You want to stop any bleed. Make sure you apply some gentle pressure. Sterile dressing for blood loss. Make sure you continually reassess CMS. You want to correct severe deformity before splinting. Again, you're going to do this with applying gentle longitudinal traction. Restore a position that will take a standard splint. Or, in some cases, you may have just to splint in place as you find it. These injuries, it could be from crashes. It seems like the ones that I've been on for the tib-fib are the motorcycle crashes, and it's a break right at the top of the boot. And the patient doesn't typically want you to cut their boot off on account of boots are expensive. So you got to use your best judgment, talk to the patient, and I've had a couple guys that just took their own boot off. They powered through the pain, even though we try to do as best we can. If you do have to cut a boot, maybe cut in an area where the boot can still be utilized, okay? Ankle injuries, same thing as far as removing a boot. You are going to have to remove the boot in order to get a good visualization of the injury and proper treatment. Ankle fractures are a result from sudden and forceful movement of the foot. Axial load is transmitted through the foot and cause the talus to impact the distal tibia. Some of the signs and symptoms are going to be the pain, deformity, and swelling, which we're pretty aware of. And you see a good amount of swelling on this foot here. Traction, apply some type of splinting material, and utilize ice to help reduce some of that swelling and some of that pain. Stabilizing the ankle fractures using a commercially available splint. We have our SAM splints, and then we also have the vacuum splints for this. Leave the toe exposed for frequent checks of distal and CMS. You want to keep it open. That way you can at least check capillary refill, making sure that they can still kind of wiggle their toes, and make sure that they have some feeling in those toes. When removing a boot, I've had to remove a few boots, and especially guys who have bought. You got construction workers who have fallen, or we had one guy who had a slab of granite fall down on his ankle as they were trying to move it at one of the local shops. Extreme pain. They don't want to move, but boots are expensive. Like I said, try to do the best you can at removing that boot. Maybe just cut the laces, or remove the laces, and then maybe just cut down the toe of the boot. That way they can still utilize the boot instead of cutting down the outside of the boot. But sometimes you have to do what you got to do in order to get the boot off. To me, it's one of those things. Just that patient's going to remember what you did to try to help them emotionally. Okay. To reduce a fracture dislocation of the ankle, you want to relax the calf muscle by flexing the patient's leg at the knee to allow the foot to move more freely. Rotate the foot back onto its normal position without forcing it. Recessing the distal pulse, good CMS, make sure that's all good to go, and splint the extremity in the reduced position. The problem, if you don't try to continually apply some type of stabilization after you reduce this dislocation, you have a potential of it going back because of a muscle spasm. So just be very cautious. I mean, it shouldn't, but you have that potential if you don't get this splinted in the reduced position. With this injury as well, you want to make sure that we're continually assessing ABCs, vital signs, get a good history. Make sure that you don't have anything else going on. Making sure that there's no other injuries, that this is not distracting you from something more serious, that this injury, as the cause of the injury wasn't from some type of a medical condition. Foot injuries are a result of fracture of the tarsals, metatarsals, or the phalanges of the toes. Calcaneus is most frequently fractured. Injury occurs when that patient falls or jumps from height and lands directly on heels. Go parkour. No parkour? Maybe parkour. Force of injury compresses the bone there, producing immediate swelling and ecchymosis. So this is an example of that. Landing on the heel. Force of the injury is transmitted up the legs to the spine, producing lumbar spine fractures. So you got to be cautious with that. So this type of injury, even though this might be the most severe, they're feeling that, you got to be cautious about and aware that they could have some type of spinal injury as well. If you suspect the foot is dislocated, immediately assess the pressure, the CMS. Address any lacerations with sterile dressing, and understand that those lacerations may cause some underlying nerve or tendon issues. You might just happen to be able to see those tendons through those open injuries. Puncture wounds of the foot are common and may cause serious infection if not treated early. Splinting a foot, you want to apply some type of material, whether it's a pillow wrapped around, a blanket wrapped around, and then rolled gauze on the lateral sides of that. However you splint it, you want to make sure that you leave it exposed so that you can continually reevaluate CMS. Transport the patient in the supine position, maybe apply some type of ice pack. And on the note of ice packs, make sure that you're not applying it directly to the skin, that you're using some type of material underneath between the ice pack and the skin so that you don't cause damage to the skin as a result of the ice pack. Amputations. Amputations can be vary from a simple fingertip all the way to an extremity. You want to make sure you immobilize the part with bulky compression dressing and a splint to prevent further injury. With this, because of the hemorrhage, you may need to apply a tourniquet. And you want to apply that tourniquet 2 to 4 inches above the injury site. But take into consideration, if vessels start retracting, you might need to apply that tourniquet as far up into the joint as possible. Okay, just keep that in mind. Honestly, I would probably, with an amputation, I would probably go as high as possible with that. But go as far as the book, do whatever the book says. Do what the book says. But real life, I'd probably go as high as I could into the extremity, up into like say the armpit, like up into the upper arm or the upper leg, to apply that tourniquet in order to occlude. Make every attempt to preserve the amputated part in an optimal condition. Want to try to protect it. Try to keep it as sterile as possible, so that if there is a chance that it can be reattached, that the surgeons have that ability of doing so. Provide rapid transport. This is going to be an early notification to the hospital as well, making sure that they realize I'd consider this a priority 1 trauma, right? Priority 1 trauma. Let them know so that they can get the surgeons ready and possibly have that trauma surgeon meet you into the ER. Hemorrhage from the amputation can be severe and life-threatening. Says, I think the book just says, quickly apply a tourniquet just above the site of amputation. Okay. With a complete amputation, wrap the amputation part in sterile dressing and place in a plastic bag. Make sure, so if we have a plastic bag, typically the bag that we have is going to be like a red bag. Make sure it doesn't get thrown away by accident, which would be bad. Do not place the amputation part in water. Consider administering IV bolus, obviously, trying to maintain good perfusion, making sure that the blood pressure is up at 90 systolic at least. You don't want it too high. Again, this is truly trying to keep that, focusing on that mean arterial pressure. Patients' emotional stress can lead to psychogenic shock. So this is where you need to really communicate, reassure that patient that you're doing they're in good hands. Talk to them calmly. Reassure them that you're going to get them to the hospital, to that next level of care, and just help them focus on breathing, staying relaxed. The other thing with the amputated part, so it says, the book's talking about, it says, like I said, don't place the part in water. You also do not want to warm an amputated part, so don't put it in front of the heater. If you have it into a bag,
or if you get it, if somebody gives you the injury and they have it, say, in an ice chest, make sure that the part is wrapped. Do not pack it in ice. But it is important to keep the part cool without actually freezing it. So you don't want that extremity to develop some type of frostbite, which would cause skin damage. General treatment is similar to fractures for sprains and strains. Rest, immobilize, and splint the injured area. Ice or cold packs over the injury. Again, you are trying to keep that ice. Utilize ice for the next 48 to even 72 hours. Compress with an elastic to help prevent swelling, and also to keep the swelling down, and also to help keep stability in that joint. Elevation is important. The splinting, again, reduce weight bearing. So this I think honestly comes back to good education for our patients. A lot of our patients, they may hear the treatments. They might have been at the ER. They might have been to the doctor for a sprain or strain, and the doctor or the CNA or the PA or the RN, whoever, has already told them how to manage this when they go home. And you might get to this patient's house, and they actually had that sprain or strain earlier in the day or last week or just the other day, and they're wanting to go back to the ER because they're in pain. Truly, do a good assessment. Find out what they have been doing to try to mitigate their own pain. Are they taking the proper pain management? Are they, when they're taking that pain management, are they taking it with food? Because it's important not to take pain pills on an empty stomach. Are they taking an anti-inflammatory? Are they taking it at the right time? When they're taking the anti-inflammatory, are they taking that with food? Because obviously that can cause an irritation of the stomach. And some of these, maybe they are supposed to be taking some type of muscle relaxer. Are they taking the muscle relaxer, or are they having muscle spasms because they're not taking it? So again, I think a lot of, especially with sprains and strains, it's important to go back, find out what they're prescribed, what information that the doctor has given them, or if this is new, explain to them what they can do at home if they decide not to be transported. Make sure that they understand the proper treatment, not to use heat. Make sure they elevate it, keep it splinted, all these points. This is some of the best stuff that they can do, and then follow up with their primary. And if they have that continuing issue, that they need to go see their primary or follow up with the ER. Questions? The educational piece, it's huge. For me, it's a huge deal, and it's underutilized, I think, for a lot of us. We can get kind of complacent, and somebody call because they have an issue, and we just package them up and we take them to the hospital, and we don't explain what's going on. We don't educate that patient of what they're experiencing may be normal, or what they could be experiencing if they don't treat them, if they don't continue with the prescribed treatments. Or, when we get to the hospital, this is what you're going to expect. This is what you could expect. This is potentially what is going to happen. You're going to have the nurses come in. You're going to have these doctors. They're going to have surgeons. You're going to have all these people come in. They're going to start asking you a bunch of questions. You got to have patience with these people. Because how many patients, if they're truly in a lot of pain, we had a patient not too long ago. She was in so much pain, she didn't even like us talking to her on scene. She didn't like all the questions. It irritated her. She was angry because all she wanted was to not be in pain anymore. And she was so frustrated. The downside was we were on a QRU waiting for an ambulance from another city to come over to transport this patient. Educate the patient. Let them know, hey, Ambulance is on the way. We're going to do the best we can to try to manage this and try to make things better. This is what you can expect. Making sure that they understand, they might be going in for a X-ray or a CT, or maybe based on what you're seeing, maybe they don't need to go into X-ray. Maybe ambulance transport is not the best route for them for a dislocated finger. Ambulance transport may not be the best. Letting them know that in some of these situations that ambulance doesn't guarantee you a room, right? Educate them that they might be triage appropriate. And they're going to be out in the lobby waiting like everybody else. So I don't know, just the education piece, making sure that they understand everything, because that goes along with your normal treatments. This is, to me, that's just as good in a lot of situations as giving them oxygen, or it's not as good, but it's as important as giving them oxygen IV rapid transport. Educate. Any other questions online? My large group of individuals here in class. Matt, Colta, Eric, Bueller. I appreciate everybody's participation, and this concludes chapter 33 at this time.